Assalamu alaikum. Today we'll talk about a very important subject which is still overlooked and underestimated subject. It is about the ocular globe injuries and ocular trauma. Why ocular trauma is very important. Trauma to the globe and ocular adnexia remain the most common emergency room consult in all parts of the world. Studies from across the globe have prognosticated poor outcomes for open globe injuries. Ocular trauma is the cause of blindness. Approximately half of million people worldwide, and many more have suffered partial loss of sight. Trauma is often the most common cause, important cause of unilateral loss of vision, particularly in developing countries. The lack of uniformity in ocular trauma reporting that existed earlier prompted the need for a robust ocular trauma classification system. A fact about ocular trauma, males tend to have more eye trauma than females, and this is already apparent from childhood, lower socioeconomic, and also the most commonly a workplace and increasingly road accident. Domestic accident, also important, or particularly important in some developing countries, is the occurrence of superficial corneal trauma in agricultural work, often leading to rapidly progressing corneal ulcer and visual loss. The WHO program for the prevention of blindness suggests that annually 55 million eye injuries restricting activities more than one day, 750,000 cases require hospitalization, 200,000 open globe injuries, approximately 1.6 million blind from injuries, 2.3 million people bilateral low vision, and 19 million with bilateral blindness or low vision. So the impact of ocular trauma in terms of need for medical care, loss of income, and cost of rehabilitation services, when indicated, clearly makes the strengthening of preventive measures very worthwhile. Generally classified into a mechanical injury, open globe injuries, closed injury, orbital trauma, and lid and canicular trauma. Non-mechanical injuries, which is the chemical injuries, radiation injuries, thermal injuries, electric injuries, ultrasonic injuries. Now we come to a very important term, which is Birmingham Eye Trauma Terminology, which is the international terminology system developed by the International Society of Ocular Trauma, came to be known as Birmingham Eye Trauma Terminology, which is, according to this diagram, classified into open globe injuries and open globe into rupture and laceration. Rupture, laceration will be subdivided into interocular foreign body, perforating when there is exit and entry and exit wound, and penetrating only entry wound. And for closed injuries, there is contusion and lamellar laceration. Closed globe subgroups classify into contusion, which is no full thickness injury, general blunt trauma, and lamellar laceration, which is partial thickness injury of the eye wall. Open globe injuries classify into rupture, full thickness injury of the eye wall by a blunt object, laceration, full thickness injury of the eye wall caused by sharp object, laceration group into penetrating intraocular foreign body, and perforating injuries. Now we'll go to an important subject, which is ocular trauma scores. Because usually in real life, we face many patients with ocular trauma, and the family ask about the prognosis. We usually say there is no prognosis. But when we study about the ocular trauma score, we can decide exactly the prognosis for each trauma. So the ocular trauma classification group was later formed in 1997 to address ocular globe injuries with an improved classification system, the ocular trauma score. System devised later enhanced the prediction of the final function visual outcome. The PET and OTS system have been considered as the standard for classification of ocular trauma. In the OTS methodology, visual acuity is estimated by detecting row of points for 5 diagnostic findings from the initial visual acuity. According to this diagram, so we have a row point of 100 points, and we classify the visual acuity in the affected eye 20 to 40. Yes, we give them 23 points. No, there is 0 point. 20 to 50, 20 to 100 with the relative apparent vector. Usually yes, there is 2 point. No, 0 point, and so on. According to the points, we classify injury to category 1, which is globe injuries, and usually point less than 45 points. Category 2, affective effect, 45 to 65 points. Category 3 and category 4 and category 5, according to the point which is resulted from the visual acuity and associated trauma. And according to the expected final best corrected visual acuity based on the sum of the row of points. So if the sum of the row of points is from 0 to 45, so the possibility of no light perception will be 74%. And possibility of light perception and half movement will be 15%, and good vision or acceptable vision is 7%. And for a point from 45 to 65, the no light perception is 27 and light perception 26. So according to this table, when you see that the number of the points will be increased, so the possibility of good vision is very good. For this example, patient reports with a blunt trauma causing ruptured globe with initial visual acuity measured to 20 to 200 with no sign of RD, no affective effect or endophthalmitis. So you calculate the OTS score for him as per initial vision score is 90. For rupture, we detect 23. So the total row is 90 minus 23 will be 67. So according to the table, OTS category number 3, which is the bracket of 66 to 80 raw scores, the significance of patient has 2% perception of light and 41 chance of vision above 6/9, which is a good prognosis. And for another example, with the patient with the globe rupture, the patient reported with the penetrating trauma with initial visual acuity measured hand movement with RD and relative affective effect. So calculation score will be as per initial vision is 70, rupture minus 23, RD minus 11, affective effect minus 10. So the residual will be 26. So according to the OTS category, it's category number 1, is very bad prognosis from 0 to 44 score. This signifies the said patient has 74% chance of no perception of light. So according to the Tibet on OTS, we have also a pediatric OTS, pediatric ocular trauma score, and also there is a toddler ocular trauma score, which depends on the visual acuity. OTS parameters for assessment include initial visual acuity and the globe rupture, and POTS parameters include initial visual acuity, traumatic cataract, wound hygiene, delay of surgery, and iris tissue prolapse. Both were reported to be accurate predictors of visual acuity. OTS was found to be of better predictive value across all age group as compared to POTS. Children undergoing intervention for traumatic cataract following ocular trauma showed that TOTS and POTS have good predictability in evaluating low-risk injury. OTS was found to perform well in high-risk group. Closed globe injury are defined as injuries without full thickness defect to the eye wall, that is cornea or sclera. These are also referred to as non-penetrating injuries. Closed globe injury are more commonly reported in pediatric age group. Injuries while playing at the home have been described as the most common cause. In a study from India, the most common mode of injuries in pediatric age group were found to be sport-related injuries, followed by wooden stick and firecrackers related, which is now is very important cause of ocular injuries. Another report documented road traffic accidents, followed by falls and non-accidental injury as the most common cause of ocular injuries. Most of the injuries are accidental and can be broadly classified as occupational and non-occupational. According to the types of injury, we have contusion, lamellar laceration, superficial bone body, and mixed. Also, there is a grade for all closed globe injuries. Positive relative effect present in the affected eye, negative relative effect absent in the affected eye. According to the zones also, we have zone 1, external limited to the bulbar conjunctiva, sclera or cornea, anterior segment involving structures in the anterior segment internal to the cornea, and posterior segment, all internal structures posterior to the posterior lens capsule. Cross-ocular examination presenting visual acuity and vision with pinhole should be tested using age-appropriate vision chart. If vision cannot be measured using vision chart, it should be recorded using finger counting and hand movement or perception of light based on severity of presentation. Following ocular trauma, open globes must be quickly ruled out. The goals of evaluation are to identify the mechanism of injury, characterize the extent of the injury, the gather relevant history Open globe injuries is diagnosed. Preparation for surgery should be made immediately. In case of significant ocular trauma, an open globe injury should be presumed until proven otherwise. Ocular globe injuries outcome are also dependent on the time to surgery. A purposeful history can rapidly profile the injury and guide further evaluation after the patient is stabilized.
You have
Any
1 minute.
injury, any injury involving sharp, highly velocity projectile, forceful blunt trauma, explosives, or firework, Ehlers-Danlos syndrome, osteogenesis imperfecta, or history of ocular trauma raise the index of suspicion. Previous large incision from ocular surgery, such as extracapsular cataract surgery, radial keratectomy, or cornea transplantation, are more likely to be open from injury. During examination, any pressure on the eye should be avoided as it can exclude extraocular content. In obvious ocular globe injuries, the technical CEDAR test is contraindicated. If the CEDAR test results in is positive, any further manipulation of the eye is contraindicated. Thank you very much.
Thank you much, Dr. Haider, and thank you for everybody in this session. We conclude